We are so excited to have Luz here, and she used to be the co-chair of the research work group. So we're always glad to have her back. And she is in Kentucky, the University of Louisville, and she will talk more about her excellent history of adolescent health research, environmental health research, focusing on asthma, and her expertise on equipment and monitoring and measurements and things. So we are again excited to have you, and let me know if you can share your screen.
Let's give that a try. It says host disabled sharing.
Sure. Okay. Oh, there we go. All right. What about now?
Yes.
All right.
Okay, does that look nice and full screen for you? Okay.
Yes, it does.
Wonderful. All right, I am happy to be back and feel very lucky to be one of the co-chairs of this group. I think it's a great group to be a part of. So I liked coming back to visit and making sure I'm connecting with each of you. So thanks for also letting me know in the chat who's on the iPhone. I like just knowing who I'm chatting with. So for this work, Liz is correct. I usually like to keep my environmental health work very focused on adolescents. I'm a big fan of that age group. I just think it's got so much potential, and I enjoy working with young people. And I have a couple of adolescents, one of them soon to be a young adult. So I have lived it now too, which is great. But this piece of work is with another group that I'm a part of, and we are doing asthma with adults. And it really came about because of the onset of COVID-19, which I know we've all lived through together and can relate to in terms of the health concerns that may have arisen in our minds for all of us, or maybe we have personally felt. So the talk today is the integration of tools for real-time assessment for residential air quality and asthma symptoms. My name is Dr. Luz Huntington Moskos, and I'm from the School of Nursing at the University of Louisville. And I'm also part of our P30 Center. I do the Community Engagement Forum, the director of that core for our Center for Integrative Environmental Health Sciences. So this work, and I'd like to acknowledge our funders. We have an R21 for this particular work, and then our P30, and then I am a Betty Irene Moore Fellow. So this is the team. I think it's important now with any kind of science you really want to tackle that works with any interesting and unique population, any new and innovative technologies, any important dissemination. It really needs a team approach, in my opinion. And so we have a great team that has really settled into a lovely working environment and a good communication pattern. So Dr. Polivka and Dr. Eldawawi are the multi-PIs for this R21. Then we have a wonderful colleague, Dr. Nyhouse, who is a physician scientist. Dr. Kramer is our biostatistician, and Ms. Kruger is our wonderful program manager who really helps us stay connected to our participants. So again, a big team effort on this part. We are lucky to also incorporate and bring on board some skills and enthusiasm from professional students involved in this work. So we have 3 students that have been quite integral in helping us with developing presentations, really helping us with user guides to really communicate well with our participants, and just really helping us with like consort diagrams and all sorts of stuff. So again, it takes a team effort. So this work originated from an online study that we deployed on different social media groups, different community partners we were connected to as colleagues. We are very interested in how the COVID-19 pandemic was impacting asthma outcomes in adults. We kept this survey very broad. It took about 25 minutes to complete. We called it the Global COVID and Asthma Study. GCAS is what we called it for short. And it really kind of helped us try to understand the lay of the land for asthma and what might be resulting from this new novel infection. And one of the pieces of knowledge that we gathered from this is disinfectant use was really climbing. We had the data to show that, there was a segment of the population that pre and post the onset of COVID, there was a big change in their use of disinfectants. With some of the different messaging that was coming out as we were getting used to COVID-19, I don't think this is probably surprising to many of us. There was a time where the community, we didn't understand this novel virus right away. There was mixed messaging in terms of how to protect yourself. There was moments where people thought that contact precautions would be a good option. And then finally, the message was coming out clearer that it was an airborne mechanism for infection. So we were growing through that together as a society. And as part of that, we had an increased documented use of disinfectants. So we really wanted to hold on to this. You can see that the green bars are the pre-use of disinfectants, and the red bars are post that was self-reported. We felt it was enough of a big difference that this needed to be explored a little bit more. And as any of you that work in the indoor environmental exposure environment, you know that this area is understandably unregulated, that families have different patterns, different habits, different cultures that will impact what their indoor environments are like. So we really wanted to explore this more. We are continuing to live with COVID-19 in its various phases. It was worth more exploration. So we decided to pull together an application for an R21, and it was a rapid response R21, which many of you may be familiar with. It has a somewhat rolling deadline so that we can be responsive. It's mostly used with disaster preparedness, different hurricanes and things that have hit us. That's what we commonly think about it with. But with COVID-19, we felt this might be a good option because of the different waves and peaks coming and going. It felt like it needed a rapid response. So this talk, we are in the midst of data collection. We are getting to a point where we've had some really good enrollment. But this talk is really going to talk to you about how we kicked this off and how we tried to integrate some of our tools for data collection. You'll see that the purpose really talks about, I'm going to share with you some of our challenges with integrating in a home indoor air quality monitor, a home spirometer, the use of ecological momentary assessment to capture that real-time self-report through the use of an app, and really see how we could pull these resources together. Most specifically, the study aims are to really think about the feasibility and usability of these tools and integrating them and seeing how responsive our participants are in having this sort of data collection. So we have the EMA, that is an app on a smartphone. We have the Aware Air Monitor. We were very interested in particulates and total VOCs, and the home spirometer for lung function. We're interested in some self-report data. We have a baseline survey that we put out when they begin their enrollment. And we're looking at, part of that study has an ACT asthma control test in it. So we're really trying to integrate these different data collections, do some triangulation with the data, and really see if we can get a nice full picture. I think pictures are great for good science communication, and I strive to be a good science communicator. So this kind of illustrates for you what we're really trying to tackle with these different devices. To the far right of the screen, you can see the Zephyr X home spirometer. So there's an app that accompanies that with a dashboard that we as investigators can access. We use the smartphone app to send trigger surveys. So on number 1, that square box is an illustration of the Omni Aware monitor. And once it is triggered, it can send a message to the EMA through a trigger survey on the app. And it can instruct you or remind you to use your home spirometer as well. So we're really trying to pull all these pieces together so we can see if you have some sort of an environmental trigger that's shot up your VOCs, Can we ask you what might be going on with a trigger survey? And then can we prompt you to use your home spirometer to let us know what your lung function might be like? That is the goal. So we really were hoping to enroll 50 adults ages 18 and over and really query them, ask them in that trigger survey at number 2, what is happening? Might you be cleaning? Might you be using some personal care product? Might you be cooking some toast in your toaster right near the monitor? Are you using your printer? Are you burning candles? We were able to kind of ask some of those questions in brief surveys and hoping we would get this nice back and forth communication. So here's just another illustration. And this one kind of adds, as well as you might know, behind the scenes, we're all using REDCap too, or Qualtrics or something like that. For us, we were using REDCap, where we're really, Dr. Polivka is a skilled REDCap user, and so we're really trying to have lots of aspects of this study contained in REDCap, data repository files, phone recruitment files. We're really trying to kind of pull things together so it's in one space and use it efficiently. So behind the scenes, we're integrating 4 different dashboards: the home air monitor, the dashboard for the EMA, the dashboard for the home spirometer, and then of course our trusty REDCap to keep it all pulled together. It has been and continues to be a bit of a worthwhile heavy lift. So this gives you just some screenshots of our user guide. We tried to make, with the help of a very savvy medical student who helped us make multiple iterations of a user guide. This is just a snapshot of the user guide on the left of the screen, and then some banner messages and surveys that you could see what it would look like on your phone. We're really just trying to catch that real time, what is happening to you in this moment trigger. So it's the integration. We're using the EMA platform to communicate with the air quality monitor and to collect that data in real time. Ecological momentary assessment, EMA, is a very interesting technology to use. There are multiple apps that are out there that can serve this purpose. Even REDCap, a very advanced REDCap user, there are ways to send out such queries. But we were really trying to integrate the technologies. So it took some time for us to talk to people about taking that home air monitor and having it interface properly with the EMA. So we had to have this API interface. For those of you that may not be familiar with interfacing these technologies, API was a new term for myself as well. I'm really lucky to have research team members that are gutsy and brave and tell us we need to just do this and we need to try it. So the integration required talking to commercial entities and their support staff and really talking to them about how these things can interface, and really stop and try to have these good conversations with software programmers and different ways that they're using these tools to, in a commercial way, to direct home sales or to business sales. So we really had to kind of up our game a little bit and try to understand these things and think about the budgetary implications. And quite frankly, we needed a lot of time before this study launched to do all these pieces, more than we had anticipated. It probably, for us as a research team, felt a little scary because there was a lot of work that had to be done on the front end, a little atypical for how you would launch a study that didn't require this technological sort of time we needed built in the front end. So study challenges, as you might imagine, with being possibly your own phone that you use, there were a lot of updates. So even on desktop computers, you have your updates for your operating systems, for your own phones. We had to make sure we were cognizant of each update, whether it be for each particular of the 3 apps, if there was an update and REDCap was offline, if there was an iPhone update or any of those things, it shifts things. It causes a slight domino effect. And at first it was a very jarring thing to consider. but we've kind of started to learn as a team to roll with it a little bit. I'll knock on wood because I'm sure there'll be another update that might throw us for a loop. But we had to learn to take that in stride as a team and how to communicate with the vendors and their staff people to help work through that. And then to go back to the drawing board, again, our medical student colleague was great because he wasn't at all worried about just updating some pieces, taking some new screenshots to assist us in the process. Another thing that has been really important is the beauty of having a biostatistician on the team. They really helped us with coordinating the interval of data. So if you have a 5-minute snippet of data and you're collecting EMA at a 5-minute interval, how do you match them up? How do you store these pieces of data? Is it making sense and really kind of coming together? We really had to have some, and we're still working through that because we have data repositories and we're really starting to get to a point where we can dive into some of that analysis and share it with participants because we have a report back component that we're dealing with to share with our feasibility study participants. So we got to have we're leaning on that good communication we have as a team, and Dr. Kramer is helping us synchronize that data interval from the different devices that we're using and from the EMA responses. So we still have plenty of work to do. And then there was always the ethics concerns when you're working with in-home devices that may have some sort of tracking involved with them, really looking at people's personal indoor lives and thinking about the ethics, being clear on your IRBs, being clear with your language. One of the things we were talking about is when can we really tell our participants, yeah, take us off that data sharing. You don't need to have us there anymore. We don't need to see that data anymore. So we really are working on making sure we're very cognizant of that because there's a lot of power in these tools and maybe we don't need to have all that power and we need to be real clear about that. So our results, we did launch this study. It is in progress right now. We have been successful in integrating these tools, thank goodness. It was a heavy lift. And so there were times where we were probably all thinking at the same time, what have we gotten ourselves into? But it is functioning very well right now. The feasibility part is necessary. We really need to see how people are enrolling, what their interest level is, how can we capture that and maintain that. We have some feasibility, we're using the usability scale for each of the tools to make sure we get that feedback. So it is functioning right now. The diverse dashboards are communicating with us and we're trying to maintain those and move through it. So I'm happy to report that. And then again, I put on there, you definitely need extra time on the front end to pull all these things and to truly integrate them so that they're useful and you have plenty of time to test. So as I stated on the different slide before this, we role played. We tested multiple times. We tried to make sure it wasn't burdensome on our participants. It's a little bit lengthy, but we were trying to make sure we could keep it in that 20-25 minute range in terms of the baseline survey. This baseline survey is actually a little closer to 15 minutes. We have, we send out a box of tools. The monitors arrive at home and then we schedule an orientation call and we have a 14-day study period for data collection. And before that 14-day period starts, we have a 3-day run-in period. So we're really trying to maintain that communication, make sure things are smooth before we launch the data collection. And we did some work on the front end amongst ourselves and we all had a wares in our homes, the air quality monitor, to try them out to see, and we all tested the trigger surveys to make sure they weren't endlessly frustrating or too frequent of a ping to kind of, we didn't want to drive our participants crazy. So we took a lot of time for instructional materials. I would recommend that as well. Making sure they're clear with screenshots, visual aids, graphics, lots of white space to make sure that they're very user-friendly. We had small postcards to make sure that we had good explanations of what is PM 2.5, what are VOCs, really trying to think about just getting those concepts clearly put across. And then we were lucky enough, our physician scientist colleague, Dr. Nyhouse, has good communication with the Chicago Asthma Consortium, and we were able to talk to the Community Advisory Board. They were the ones that get credit for the reduced trigger surveys and the reduced check-ins, and they were the ones that get credit for the idea of this 3-day run-in that really helped us make sure that everything was moving smoothly and well connected for our participants. So that was great and essential to a good working process. So discussion, I think I'm doing good on time. There might be something in the chat. Liz or Lisa, is there a question in the chat that I can answer at this point?
Not yet.
Okay, just making sure. The discussion portion, we really, again, launched everything and put a lot of time on the front end. Role playing, practicing, making sure good communication within our research team and also with the vendors of the tools and devices we were using. All of that was essential and took more time than we had thought, but has been worthwhile and has still allowed for a successful enrollment. We recorded all our training videos so that each research team member could access it again. That's been essential because we're not always doing orientation calls. We share them, and there's a couple of members that do the majority, but you got to jump in sometimes. So those calls and recordings are still there so you can refresh some ideas of how to do this smoothly to make your time with the participant efficient and worthwhile. Again, more time on the front end to help troubleshoot well. We meet weekly for 2 hours. We have for the last 2 years plus. So we were meeting weekly prior to March 2022. So that really helped. We had that established team communication, team rapport that really helped us launch this and maybe not go too crazy with the integration of the tools. And then really have those team members that have those advanced skills in data linkaging, data harmonizing, data processing. We will really be using that shortly and accessing that with our colleague, Dr. Kramer, into its full potential. So the conclusion, I hope I'm leaving time for questions and some collaborations or innovations you might be thinking of, but these are complex tools. Sometimes they don't play well together and you need to really map out some time and be easy on yourself and your team if it takes longer than you thought it would take. That time on the front end, although a little stressful for us, has served us very well. And I believe our participants are feeling as though they're well taken care of. We're still learning about that, and we will definitely be combing through the usability surveys that we have to make sure that they were well received. And we're glad we've invested that time and will continue to invest that time in usability and acceptability measures. Integration of the multiple platforms, we think it's valuable. We like the idea of subjective and objective data, real-time collection, letting our participants in on this. Some of the devices that we use are blinded on the display screen. So that small monitor that sits in the home, it has a display, but it's turned off for this portion of our study. But we're really playing with the idea of leaving that on and really kind of having our participants have a little bit more lifting of the veil and seeing some of those changes, and then really seeing how that might trigger health behavior change in the moment. So there's a lot of growing for us to do with this work that we're very excited about. And then we're hoping to build this and scale this up and really think about the scalability of this work. How can we make it easier? In these busy times with American culture and still living with COVID in its different aspects, people's time and schedules are really busy. There's a lot of stress in the world right now still. And so making sure we can connect with them on the phone, there are challenges to that. And then we've talked about this just recently in our last meeting on yesterday morning. There are so many robocalls and so much text messaging that happens in an automated way. And it really inhibits and colors the way we can communicate with our participants, even if we have a nice rapport and they know our study team from the GCAS work, because I should mention to you that anybody that's in this particular study was recruited from the GCAS group of 900 plus people that participated in that original survey. They checked a box that said they wouldn't mind being contacted for future work. And so we have a somewhat rapport. They know us a little bit as a research team they've interacted with before, even though it's virtual. And we still have trouble getting in touch with them. People screen their phone calls. There's just so much happening right now. So that's something that all of us as researchers have to contend with as we're trying to make real good connections with our participants. But we're hoping to scale it up. I can report to you that we have the protocol for this study published in JMIR, so it is open access and you're available to you if you'd like to download it and just get some more of the finer details of how we really kind of launched this study and got it rolling. And then you'll see my colleagues and our student colleagues are co-authors, which we're very excited about. And then that is the nuts and bolts of putting this together. You might have some questions about the finer details of how we've been able to accomplish this, which I'd love to answer if anything comes to mind. I can tell you right now that we have enrolled 58 participants. That is enrollment. So consenting and moving into the baseline survey. From the baseline survey, you have to do the orientation call, receive your devices, then you have to do the 14-day study period, and then you do the usability scale. So we're talking about, 14, 17 days with the run-in. So we're still in the process of seeing if people can stay engaged with us for that whole period of time, where they might drop off, how we're moving them through. So we're still enrolling people and we're still kind of exploring some of that so we can get a real good sense of the feasibility of this work and a real good sense of how to scale it up. So that's really all I've prepared. I hope, yes, it's like 3:40 if you're Eastern time. And I'm glad I really try to leave some time for questions and for collaboration and discussion. So yay me, I did that.
Liz, I just wish you were like my professor for every course. You're so engaging, so positive. I love it. Oh, wow.
Great, thank you. I don't have all the gifts that a researcher needs, but I'm glad I have that one. And so I can be a good team player and really just share my love of the science. Thank you, Liz.
And Anne-Marie, one of our previous speakers as well. Are you first up with a question?
I can be. Thank you so much, Luz. I am so interested in this. I've never used it myself, but this ecological momentary assessment, and I've thought about it a lot and then thought about just how hard it would be and kept thinking about other things. So I'm curious to know more about the kinds of questions that you were able to ask. So is it at the moment of a symptomatic event? I heard you say the piece about like if the candle was burning or if the toaster was on or that kind of thing, but can you talk more about the kinds of information that enabled you to collect that would have been more difficult with a paper-based or web-based survey?
Absolutely. So Anne-Marie, I loved your talk before too. I was in the audience, just so you know. This EMA, we really kind of dug deep to understand it because it's been mostly used with mental health researchers. So mood-based anxiety, depression symptoms. A lot of the literature that's out there right now is focused more on the mental health researchers. That's where I saw the bulk of the research that's available with this methodology. And it has some unique aspects to it. So I'm also right in the process of doing a systematic review with a different hat. So it's young adults and physical activity in EMA. So I'm learning more and more about this methodology. The idea is that you have 3 separate kinds of surveying if you're doing it to its full capacity to really capture this real-time concept. You do these routine scheduled surveys. So for us, we had a morning survey, comes across at like 8 a.m., 9 a.m. every morning. And it prompts you to take your home spirometer as kind of like the baseline for the day. It's very straightforward. And all of these are like 4 or 5 questions. They're rather short and they're meant to not take a lot of time. So you do the scheduled survey, then you have random surveys. Nothing triggers them. They just come out randomly 2 or 3 times a day. You set that in terms of how many random you want. And you set windows of time. So the random one can happen between 8 and 12 and 12 and 5. And you have to program it so that it turns off and doesn't interrupt people during their potential sleeping hours. So we kind of had to query people on that as well, because you don't want this to be a nuisance. And most of the research that I read only did this for 1 to 2 week periods. So it's just this snapshot of just a week or 2. And it's a lot of data. So it makes sense that that's how they're using it right now. And then third is the trigger survey, which we were most excited about because that's why we had the API with the home air quality monitor. The air monitor would rise above a threshold for particulate matter and for VOCs. And for VOCs, it's like 333 parts per billion. And so we would have that cut point, you know, that threshold there. If it rose above, a trigger survey was sent. It would be short, 4 or 5 questions, and it would ask, are you engaging in any of these activities? Have you used any of these things? Could you please take your home spirometer now? And then it would be done. 4 or 5 questions, 4 or 5 questions. I still think that with the baseline scheduled, the random and the trigger, it can still be burdensome. So that's why this is truly a feasibility study, but there's so much great potential there to just really communicate back and forth with your participants that we're hoping that it wasn't too burdensome for them. Does that help?
Yes, thanks. I did the piece about the 3 different time periods I hadn't realized, which would provide a lot of different, in the use that I'm thinking about, a lot of different data. And also hearing you say that it's only 4 to 5 questions each time to reduce the burden. That's also helpful to hear. Thank you.
So for us, the license is, I'm frugal. So by my expectations, it's a little expensive, right? So this is a budget heavy, all the money went to equipment and to licensings, and a lot of it went to that, right? So it's good to just keep that in mind when you're writing these up. You need to have a healthy equipment and licensing budget. And then I would also like to recommend to you doing this systematic review. There are systematic reviews that exist about how to report EMA findings. And doing this systematic review that's current, boy, we're not doing a very good job with that. So there's no usability, there's no acceptability in a lot of these studies that we're reviewing for this report. And there is it's called a CREMAS checklist. I'll type it in the chat, CREMAS. It's in one of the publications. If I remember, I'll send it to you, but it kind of holds your feet to the fire for good reporting on EMA. So if you're going to dive into it, I would highly recommend searching out the CREMAS checklist so you can really see what you need to report to use it well and to use it to its full potential.
Definitely still in pre-contemplation, but
yes. Oh, and that phase can be long.
Yeah, I may stay here a little longer, but this was really helpful to hear. Thank you.
Sure.
Other questions from anybody else besides Liz and me? Because I know I have a whole list of questions, but I want to give other people the opportunity to ask questions.
I also want to say hi to Julie because I know she's one of our Erie people and I love that she's here.
Hi, I'm in my pajamas in the afternoon, so I didn't have my
That's awesome.
screen on.
That's one of the good sides of living through a pandemic, right? No problem with the pajamas and at the afternoon. Okay, and I see a message from Maggie.
Yes.
Yes,
Maggie,
who had to leave, but was fascinated by this, so that's really great. Well, I might ask a question then, if I could.
Please.
First of all, I love to learn about this study. This is amazing. I mean, all that technology interfacing, I can imagine. And like an R21 only gives you so much money to get through, but I think that having just sat on a study section where we were looking at proposals that move, that were R01s. The strongest ones were things like this R21 that, they'd had the experience in R21 to learn about kind of the chaos, work it out, and then launch the R01. So I think this will just be perfect to move forward. And what I was thinking about is, there's this big move on implementation science now, right? And there's this call that I'm sure NINR would love to sponsor an R01 using that mechanism for implementation science and environmental health specifically. So I think this would be a perfect, because right now you're doing feasibility, which is part of implementation science, but then you've got all those tools there to really evaluate the reach, the acceptability, the adoption and maintenance, the sustained use. I mean, I guess you're looking at getting data from people to you to understand the exposures. But I think like the idea of when you were talking about unblinding the monitors and seeing how people react to the changing levels, like, do they see that their PPVs are, 100 for VOCs and they open up their windows, and so those kinds of opportunities to think about like what kind of behavioral interventions could you create to address high VOCs or high PM, like even sending an EMA that says your VOCs are high, open your windows, and like actually it becomes like a behavioral intervention, which I think is really like super cool. To do that in real time is amazing. I know I can hear how stressful it was to start it, but it's gonna pay off because it's a really neat project.
I really believe in the people's capacity to be wonderful partners in this kind of science, but there's such a block in terms of people feeling that they can't grasp the science. And I think as scientists, we just need to be better facilitators. So some of that is really on us to we hold it up high, hold the science up high on a pedestal, and we don't share very well. And so these tools, I think, have the capacity for us to share a little better. And we as a team have all been very big proponents about lifting the veil and showing the displays a little bit more and seeing how that moves us and gives us some momentum. So those are talks that we are very seriously taking for the next iteration of this as it scales up. So yes, and this is another reason why team science is so wonderful, because I'm a big proponent of that, and I'm on the team to help with the report back and maybe to give a little more young adult experience, while Barb Polivka is the older adult expert, and you span the whole realm. But Dr. Kamal Eldarawi is the gutsy one, because if it had been up to me to interface this API, no, I wouldn't have done it. I'd have been a chicken. I'd have said no, and I'd have left the room. But your teammates, your research teammates, help you to be brave. And he's like, no, we got to try this. Let's give it a shot. And so I just, take a deep breath, and I'm a part of a team. I don't have to shoulder all that nervousness by myself, right? So it's very nice to work with colleagues that just, they can share some of that gutsiness.
Right. And that multidisciplinarity of it, right? You've got some people that are techies, and you've got some people that want to give the report back to people for, to be fair to them, right? I was wondering what is the compensation for the people to do the 14 days and the 3-day run-in and all that? What do they get?
So when we did the survey, the GCAS survey, we had it was purely online, 25 minutes, and it was a raffled off gift card for every 50 participants. Then they checked the box if they wanted to be recontacted, which all of these individuals that we're with, and their compensation is their home air spirometer, which is $125 value. So they get to keep those. And then we are doing a 1-page report back on their particulate matter and their VOC. So we're sharing that back with them.
That's great. That's good. Yeah. Yeah. I think it sounds really super. I can't wait to see the next phase.
Yes. So right now, we're doing some quick sort of trending analysis so that we can report back in a good time frame. Because I think we all know that if we can just get a little bit report back, even if it's preliminary, just to stay connected to our participants, we're working on that. Then we're going to really start to synchronize and harmonize some of that data. Our 2 years of R21 timeframe, not including a no-cost extension, will end in January, February-ish. So we're kind of in the thick of it right now. It'll be a little longer till we get some really good chunky data out to people, but we're getting there.
Mm-hmm. I was thinking, I wonder if there's, asthmatic parents have asthmatic children. I was just thinking, if you had kind of enrolled dyads of parents and children and had some kind of, that would be, I think, an interesting way to, especially since I think parents, are always worried about their children's health. So might be more responsive to opening the window or taking the kid outside or shutting the window if there's pollen or whatever, and it'd just be interesting to have kind of a household level intervention would be something interesting too.
We've talked about, the individual, the family unit, and the community level with some indoor and outdoor data collection to really give people a sense of what they're contending with, what's their real context for these kind of concerns, their respiratory concerns. And, I don't know that we always talk about how socially networked a family is. You share those diagnoses in one way or another, right? The child may be the one that's having the symptoms, but maybe, adults have more minor adult forms of asthma, or maybe they're sharing in the mental health stressors of having a chronic illness. We don't really experience health or illness in isolation. We share it with the people that we live with. So I agree with you, having that kind of family unit discussion about these things, particularly since we're sharing the same air in our homes, right? We share it as a family unit. I think it's great. I love the idea of just looking at that in a more complex sort of way.
Yeah. Other questions? Liz? Anybody else?
This was fun. I like this. I'll come back.
Oh, yeah. Okay. Do you want to share RWG next?
No, let me launch my study a little bit more and then we can talk.
I was just listening to you with all your discussions about the R21, and I'm like in the second year of my R01, and it is just crazy making, it is so much work that it is really challenging to get all the pieces together when you have a complex study or you have complex equipment interfacing, and it's a lot. So take your time.
You gotta be brave, right? Because it is a little chaotic. I think even if you've planned something really clearly, there's going to be hiccups. We were dropped from our first EMA provider. So the quotes and the budget that we had gotten together with our first EMA provider, all that fell through within the first 30 days of getting funded. We had all those documents and budgets, and we called them up and say, hey, we got funded. And they're like, we don't have room for you. Our tech support says that they're maxed out and we won't have room for you for 6 months.
Oh my gosh.
6 months of a 2-year grant, that won't work. So you have to be ready to kind of just roll with the punches and just know it'll work itself out.
Yep, that's for sure. And adapt, right? The R21s are supposed to be risk-taking, high risk, high reward. So yeah, I know with mine, I had proposed 60 and the budget only allowed 50. I had to reduce the numbers because you just have to adapt as you get funded and you say, I'm going to do all this. And then you're like, I can't do all of that. There's not enough money. But anyway, Liz, do you have any questions or any comments or?
just to say, stuff like this is so helpful for junior faculty, you know, just to hear the ins and outs, even if it's not a project, you know, that I'm gonna do, these are still tips that will work. So I appreciate sharing all your experiences.
Thanks, Liz. I appreciate it. I like seeing all of you and just kind of being in the same room together and sharing. It just helps kind of keep your enthusiasm up for the work. Thank you for having me.
Yeah, and we're not at ANA this year, are we? We're not. I remember running into you. That's probably the last time I saw you in person, Luz.
Oh, it's been a while, huh?
A long time ago, for sure. Well, thank you so much for joining us. My dog knows when I'm signing off.
Thanks for having me, everybody. Please take care.
Yeah, take care too. Good luck. Bye.
Bye. See y'all next month.